Now I would like to invite next speaker, Dr. Rohit Swami, consultant medical oncologist from Jaipur. He will be speaking on neoadjuvant pembrolizumab for early stage NSCLC.
Hello, am I audible? My slides are visible?
He's there, he's saying. So you're not audible.
I'm not audible. Now am I audible?
Yes, sir.
Yeah. So good morning everyone. I am presenting role of pembrolizumab monotherapy in neoadjuvant setting in early stage NSCLC. So as you all know that checkpoint inhibitors prolong benefit for some advanced NSCLC patients, and early stage NLCLC 5-year survival rate in stage 2 is only 60%, and in stage 3 is still 36% post surgical resection only, which are unsatisfying. And even adding adjuvant or neoadjuvant chemotherapy in this setting gives us only 5% benefit in 5-year survival rate. So, in many different malignancies like melanoma or recurrent glioblastoma, it has been seen that giving checkpoint inhibitors in neoadjuvant setting is more beneficial than giving checkpoint inhibitor in adjuvant treatment. And neoadjuvant checkpoint inhibitor is being explored in several studies, but mostly in combination with chemotherapy. And we don't know optimal neoadjuvant checkpoint inhibitor regimen as a monotherapy in this early stage NSCLC setting. So this is a phase 1 study which explored the role of monotherapy, feasibility and safety of pembrolizumab in early stage NSCLC. Primary endpoint of this study was safety of pembrolizumab in this setting and recommended phase 2 dose schedule and pathological response achieved after pembrolizumab neoadjuvant therapy. Secondary endpoints for recurrence-free survival, overall survival, and exploratory endpoints for exploration of mechanism of response and resistance to pembrolizumab in early NSCLC. So patients were enrolled in 3 cohorts, and cohort 1 dose schedule was to receive 1 cycle of pembrolizumab followed by surgery after 3 weeks if there is no dose limiting toxicity. Cohort 2 was planned to receive 2 cycles of pembrolizumab 3 weekly, and surgery was planned after 2 weeks. And in cohort 3, again 2 cycles of pembrolizumab 3 weekly, and surgery was planned after 1 week of last dose of pembrolizumab. There was also expansion cohort which was planned to receive dose schedule as per cohort 2 and cohort 3. So this study was started in January 2017, and expansion cohort target was increased to 29 to maximize trial validity. And enrollment was planned to be till January 2020, but enrollment was closed in November 2020, and 26 patients were enrolled because of slow recruitment in view of COVID-19 pandemic. So total treated patients were 26. Out of these 26 patients, 3 patients in cohort 1 received 1 cycle of pembrolizumab followed by surgery. And the patients in cohort 2, cohort 3 and expansion cohort who received 1 cycle of pembrolizumab was 23. Out of these 23 patients, 2 patients had severe adverse event and surgery was cancelled in these 2 patients. And 21 patients received both the doses of pembrolizumab, and 1 patient refused surgery among them. So total patients who underwent surgery were 20 who received 2 doses of pembrolizumab. And out of these 23 patients received 1 dose of pembrolizumab. So coming to the results, there was no dose schedule limiting toxicity in any of the patient. All the 26 patients, there was no DLT, and 21 patients received 2 cycles of neoadjuvant pembrolizumab. So in this study, total 7 patients achieved major pathological response, which was defined as less than 10% of viable tumor cell. And out of these 7 patients, 3 patients has complete pathological response. And all of these 7 patients belong to the cohort who received 2 cycles of pembrolizumab, and where surgery was done after initiation of treatment, that is after first cycle of pembrolizumab, after 5 weeks of first cycle of pembrolizumab treatment. And there was no correlation seen with the PDL1 status or tumor size or nodal status with attainment of major pathological response. And as I already told, all major pathological response were seen in the patient who has significantly long interval from initiation of pembrolizumab to surgery. So, coming to patient characteristics, 7 patients attained major pathological response, and there was no correlation of attainment of major pathological response with smoking status or pathology or tumor size or nodal status or PDL1 status. Only significant factor uh, which had significance in attainment of major pathological response was initiation of pembrolizumab to the surgery interval, and median interval in a group of patients who received major pathological response was 43 days as compared to 36 days in patients who were not able to achieve major pathological response. So coming to adverse event, around 81% of the patient had adverse event in this study, and serious adverse events grade 3-4 were seen in 35% of patients. And these serious adverse events were continuation of chest drain till post-operative days of more than 7. Two patients had pneumonia, two had empyema, and one patient each has sepsis, myositis, myocardial infarction, myocarditis, encephalitis, and hepatitis. Treatment-related adverse event grade 3-4 were seen in 2 patients, and TRAE leading to treatment delay was seen in 1 patient, and discontinuation of treatment because of treatment-related adverse event was seen in 2 patients, but there was no dose schedule limiting toxicity in any of the patient. So after recommended phase 2 dose schedule was pembrolizumab 2 cycles at 3 week of interval, followed by surgery after 2 week of last dose of pembrolizumab, and major pathological response was observed only in the patients who had 2 cycles of pembrolizumab and had surgery after 5 week of initiation of after first cycle of pembrolizumab. And when analysis was done in the patient who went with this schedule, this recommended phase 2 schedule, so there were 16 patients who received this dose schedule, and out of this, major pathological response was seen in 44% of the patient, and complete pathological response was seen in 19 patients. And
So, sorry to interrupt, just one more minute to go.
yeah. So relapse-free survival in the patients, which were 23 patients who received 2 doses of pembrolizumab, was 100% at 1 year and 92.3% at 2 years. And overall survival was 100%, and at 1 year and 2 year survival was 93.3% in all the population of the study, that is 26 patients. Median follow-up was around 23 months. So take-home message is that neoadjuvant pembrolizumab is safe and feasible. There is 8% rate of grade 3-4 treatment-related adverse event in this study, and there was no apparent relation to treatment surgery interval. Outcome in entire study group, 27% rate of major pathological response and 12% rate of pathological complete response, and 2 doses of neoadjuvant pembrolizumab at 3 week interval followed by surgery after 2 weeks of the last dose of pembrolizumab is a recommended dose schedule for phase 2 study. And when we look, the 16 patients who received the treatment as per to recommended phase 2 dose schedule, major pathological response was seen in 44%, and complete pathological response was seen in 19%. So pembrolizumab is feasible in neoadjuvant setting, and by the recommended phase 2 dose schedule, major pathological response attainment rates is around 44%. Thank you.
Thank you, sir. With this, we move to our next abstract. We invite Dr. Narmada R, consultant medical oncologist at Apollo Proton Cancer Center, Chennai, to review the next abstract.
Slides are not visible.
Narmada, are you there?
Just before she was there, I think still she's there, but any connectivity issue? Okay.
Dr. Narmada, you are still not audible. She's there on. Slides are moving for her end or okay, that means she's. Okay, I think we will take the next abstract.
Next, yeah.
Yeah. Uh, uh, we will start with the next speaker. I invite Dr. Prasad Narayan sir, senior consultant medical oncology and director of medical oncology, Site Care Cancer Hospital, Bangalore. He'll be speaking about neoadjuvant chemotherapy alone versus, neoadjuvant durvalumab with or without stereotactic body radiotherapy. Prasad sir, hai kya rakha?
Third. Good morning. At the outset, I would like to thank the organizers for this
Sir,
opportunity.
yeah.
The next 7 minutes or so, I will be discussing about this study, which is a phase 2 randomized trial, which looked at neoadjuvant durvalumab alone or along with the stereotactic body radiotherapy in patients with early stage non-small cell lung cancer. So we know that there have been attempts at neoadjuvant systemic therapy, be it chemotherapy or immunotherapy recently in early stage lung cancer. But adding SBRT as an immunomodulator hasn't been tested in this context. And that is the basis of this study, which looked at pathological CR as the primary endpoint. And the PAT CR rates usually with any sort of neoadjuvant therapy has been into the tune of 15 to 45% in different studies. So it's a randomized phase 2 single center study. One arm had 2 cycles of durvalumab, the other arm had durvalumab plus SBRT 8 gray, 3 fractions. Primary endpoint, major pathological response, which is defined as less than 10% viable tumor cells. 96 patients screened, 60 enrolled, 30 in each arm. And from this 30, 26 in each arm underwent surgery. So, and the post-operative treatment was radiation or chemoradiation as per the standard guidelines. What happened to those non-surgical patients, which is our main concern when we treat an early stage cancer with a neoadjuvant therapy? The single agent arm, 4 patients who did not undergo surgical resection, 3 were not explored because one refused, one had a stroke, one had bone metastasis, and the one who was explored had pleural metastasis, which is a common thing in lung cancer. When we stage a patient as early stage and we go in, we might find metastasis. In the combination arm, one patient who was not explored had a cardiopulmonary event. 3 of them were explored for surgery. One had lung mets, one had pleural met, and one had aortic invasion, which made it inoperable. Then from the demographics, what were the key points in these 2 studies? My first look was whether how many patients would have had a stage 3 disease. So almost half, 47 or 40% in both the arms had stage 3 disease. And invasive mediastinal staging. This study had a mandatory PET-CT and invasive mediastinal staging in those who were indicated. It was done in 40% and 43% respectively. Adenocarcinoma was more than squamous cell carcinoma. The key thing I would say, which might have influenced the result or not, we can't say, because both sides got the durvalumab, was the PDL1 expression. The PDL1 expression percentage more than 1 was 77% in the combination arm, which can explain the differential results actually. We can't say with a small study. EGFR mutant patients were almost 20% in both the arms. So major pathological response occurred in 2 patients, that is 6.7% in the monotherapy arm versus 16 patients, which is 53.3% in the combination arm. Among these 16, who had a PAT-CR, who had a major response, 8, that is 50% of them had a pathological CR, which is significant. So the study met its primary endpoint straight away. P-value is highly significant, and there is no need to even put a statistical calculation to find out this difference. What were the adverse events? The second cycle of durvalumab was withheld in 3 patients of the combination arm. Grade 3 or 4 adverse events occurred in 17% of the patients with monotherapy and 20% in the combination. Serious adverse event, 2 in each group. One of pulmonary embolism and stroke in monotherapy. We discussed that in the patients who did not undergo surgery. And 2 SAEs of one of pancreatitis and fatigue in the combination arm. So a typical immunotherapy study, which with the AEs being described are very similar to that. So as a discussion, the trial met the primary endpoint, which was whether adding SBRT will improve on outcomes from durvalumab alone. And as I discussed in the demographics, there were differences in the PD-L1 positivity among patients in both the arms. Now, since this study had durvalumab in both the arms, PD-L1 was more in the combination arm, we don't know whether the effect of SBRT, just giving SBRT 8 grade into 3, was the impact in improved PAT-CR, or was there any effect of a immunotherapy immunization? And that cannot be done in this study, in such a small study, but definitely this rakes up this question of adding SBRT as a convenient mode of radiation along with 2 cycles of immunotherapy. The pathological response in the control arm was less than that is reported in other trials. One possible explanation could be the lesser number of patients with PD-L1 positivity, or there could be any other reason for that. So my take from the study, is it a study worth discussing? Yes, it is a study worth discussing, because the SBRT 8 grade to 3 is easily possible as a neoadjuvant arm. In this study, the patients were taken for surgery. The median time to surgery was 4 to 5 weeks, which is significantly less than most of the other neoadjuvant studies. So in that way, it is a simple study to be, and the period was not very high of the patients being diagnosed and waiting for the curative intersection. And if 54% of them will get a major pathological response, it's worth doing something before surgery. And so definitely the study opens up a question of trying this in a larger study. And most of the studies which are looking at combination of chemotherapy plus immunotherapy combinations, there are phase 3 trials which are looking at this question in this era. So looking at a combination as a potentially curative Indian therapy is something possible. I'm sure the surgical colleagues will now jump up on me, whether we can just give immunotherapy and radiation as a combination and cure more patients of early stage non-small cell lung cancer, be it adenocarcinoma or squamous cell carcinoma. So the study definitely met its primary endpoint, worth discussing and worth taking to a different level in a different design. That's my take from this study. Thanks a lot for the opportunity.
Thank you to all the speakers and the chairpersons of this session. For the next session, I would like